Hello and welcome to today's Explainer. All right, so today we are stepping way out of the realm of casual, everyday psychology, and we're diving deep into the profound, deeply complex clinical realities of obsessive compulsive disorder and post-traumatic stress disorder. Our core focus here is to teach. We want to strip away those colloquial misunderstandings and really examine the true mechanics of these conditions. Because by doing that, we can build a much clearer, more empathetic picture of exactly how the brain processes fear and anxiety.
Okay, let's dive right into this. Think of this as our roadmap for today. We're going to logically unpack both conditions, starting from the problem to the origin, right through to the solution. So we'll cover defining the disorders, key clinical features, the roots of the disorders, and finally, evidence-based treatments.
Section 1. Defining the disorders and establishing a clinical baseline.
It's absolutely crucial we start with strict clinical definitions before looking at the symptoms. So let's look at obsessive-compulsive disorder, or OCD. It really hinges on two things, obsessions and compulsions. Obsessions are those intrusive, unwanted, recurrent thoughts or urges that cause severe, marked anxiety. Compulsions, on the other hand, are the repetitive behaviors or mental acts performed to reduce that anxiety or to prevent a feared event. You can kind of think of it as a lock and key mechanism, right? The obsession creates this agonizing distress, and the compulsion is the desperate, immediate attempt to alleviate it. Moving over to post-traumatic stress disorder, or PTSD. Now, this definition hinges on the development of characteristic symptoms following a very specific type of exposure, actual or threatened death, serious injury, or sexual violence. And what's vital to teach here is that exposure doesn't just mean a direct personal experience. No, you can develop PTSD by witnessing an event as it occurs to others, by learning that a violent or accidental event happened to a close friend or family member, or even through repeated extreme exposure to the aversive details of traumatic events, which is something first responders experience all the time. Okay, so we have our textbook definitions down, but you might be wondering, what do these disorders actually look like in everyday life? How do they manifest? That brings us to Section 2, key clinical features and identifying the symptoms. Let's look at how these present practically. With OCD, the defining features go way, way beyond just a preference for tidiness. To meet the actual clinical threshold, these cycles have to be severely time-consuming, we're talking taking up more than 1 hour per day, or they have to cause massive impairment. The themes usually fall into some pretty heavy buckets: contamination and washing, intense needs for symmetry and ordering, deeply distressing forbidden thoughts, or an overwhelming fear of harm that leads to relentless checking. This far exceeds normal double-checking. So the crucial point is this core realization about OCD: insight. Usually, the person totally recognizes that their thoughts and behaviors are excessive or irrational. Now, their insight can range from good to poor to completely absent, but typically they know what they are doing doesn't make logical sense. Yet, and this is the heartbreaking part, the anxiety driving the compulsion is physically and mentally so powerful, they feel entirely unable to stop. Shifting our focus to the practical presentation of PTSD, the symptoms fall into 4 main deeply distressing clusters. First, intrusion symptoms. This includes things like flashbacks and nightmares where the person genuinely feels they are reliving the trauma. Second, a persistent avoidance of anything at all that reminds them of the event. Third, negative alterations in cognition and mood. This can look like distorted self-blame, a profound feeling of detachment from others, or just persistent negative beliefs about the world. And fourth, marked alterations in arousal and reactivity. This is that intense state of hypervigilance, having an exaggerated startle response, unexplained irritability, or severe sleep problems. It is an incredibly heavy burden to carry. And just like OCD has a time criteria, so does PTSD. To be clinically diagnosed, these symptoms must last for more than 1 month and cause significant impairment. This vital distinction is what separates PTSD from a temporary acute stress reaction. Because, it's completely normal to have a severe response immediately following a trauma. But when it persists past that 1-month mark, well, that's when we enter clinical territory. So we know what these disorders look like on the outside. But what is literally happening inside the brain to drive these powerful responses? Section 3. The roots of the disorders, etiology and origins. We're going to systematically compare the biological, psychological, and social origins of both conditions now. And this brilliantly illustrates the differences. When we compare the biology, distinct patterns emerge. With OCD, we see abnormal activity in a specific brain loop involving the orbital frontal cortex and the basal ganglia, alongside serotonin dysregulation and genetic loading. But with PTSD, the biology is basically an alarm system stuck in overdrive, a dysregulated HPA axis, amygdala hyperreactivity, and even reduced hippocampal volume. Psychologically, OCD is driven by a loop of negative reinforcement, while PTSD is driven by fear conditioning to trauma cues. And socially, well, while OCD might have some familial modeling, PTSD risk is heavily influenced by the severity of the trauma, prior trauma, and a lack of social support afterward.
Actually, I want to isolate a really fascinating psychological concept for OCD: thought-action fusion. Look, everyone gets weird, fleeting, intrusive thoughts, right? Like, what if I swerved my car right now? Most people easily brush that off. But in the cognitive model of OCD, those completely normal intrusive thoughts become obsessions because the brain incorrectly processes them as highly significant or as dangerous as the action itself. The brain literally fuses the mere thought of doing something bad with the actual physical act of doing it.
Now, for PTSD, the psychological root centers on emotional processing. Normally, a trauma memory should be filed away as something safely in the past. But in PTSD, those memories are not adequately integrated. They are essentially left sitting out on the desk, so to speak. So the brain's alarm system incorrectly links these life-or-death fear responses to everyday, completely safe cues that just happen to remind the brain of the original trauma. So we are looking at some profound biological misfirings and some incredibly deep psychological wounds here. It can honestly feel overwhelming, but that leads us to the most important question of this explainer. How do we actually heal them?
Which brings us to Section 4, Evidence-Based Treatments and the Path to Healing.
For OCD, the absolute gold standard behavioral therapy is exposure and response prevention, or ERP. It's a grueling but highly effective two-step process. First, the patient is safely exposed to their obsession trigger. Step 2 is the hardest part: prevention of the compulsive ritual. By forcing the brain to sit with that extreme anxiety without performing the compulsion, the brain eventually learns the feared outcome won't happen. It completely shatters that cycle of negative reinforcement. When treating PTSD, the primary psychotherapies like trauma-focused CBT, prolonged exposure, and EMDR are highly structured interventions. They aren't just your standard talk therapies. They are specifically designed to help the brain finally refile and integrate those unintegrated traumatic memories so they no longer set off the body's physiological alarm system in the present day.
Now, what's really interesting about this is how pharmacology differs between the two. For OCD, medications like SSRIs are incredibly effective, but they typically require much higher doses than what you'd use for standard depression. In stark contrast, for PTSD, SSRIs and SNRIs are often used more as an adjunct. They help turn down the overall volume of that hyperarousal just enough so that the patient can actually tolerate the heavy lifting of the trauma-focused psychotherapies.
Well, we've covered a lot of ground today: the strict definitions, the daily clinical realities, the complex origins in the brain, and the heavy, rigorous treatments these patients undergo. So I want to leave you with this provocative thought. Knowing the profound biological and psychological realities of these disorders, how can we change the way society colloquially uses terms like OCD and traumatized? My hope is that you take what we've taught today and use it to elevate the conversation around you, helping to destigmatize true mental health conditions by respecting what they actually are. Thank you so much for joining me for this explainer. Keep learning, and I will see you next time.